Hello, everyone. Welcome. We're just getting started here as people start trickling in. My name is Audrey Guay. I'm an organizer with the BC Health Coalition, and I'll be your organizational host for today's session. I'm joining you today from the BC Health Coalition's head offices in Vancouver, located on the unceded Coast Salish territories, which have been shared since time immemorial among the Musqueam, Squamish, and Tsleil-Waututh nations. And wherever you are today, I invite you to offer your gratitude and recognition for the generations of Indigenous caretakers who teach us that our health and well-being are inextricably linked to the land and one another. And you may have noticed we've invited you to share your name, the territory you're joining us from today in the chat. And if you're also representing an organization, we would love to hear which organization that is. So today we dig into the gaps in seniors' care. On behalf of the Health Coalition and the Council of Canadians, I want to thank you all for joining us for this second webinar on seniors' care. Last week, we had over 350 participants join us for our webinar on removing the profit motive from long-term care. It was a really energizing event, and we know that there's a lot of people out there who care about seniors' care. If you missed last week's webinar, you can find a recording on our website, and we will put the link to that in the chat. We do hope that we'll be able to continue doing these webinars on seniors' care and moving more into action and training in the new year. So we have about 180 participants joining us so far, and a great lineup of speakers that we're going to introduce shortly. But before we begin, I want to take you through some housekeeping notes. We're recording today's session. You should receive a link to the video within a week, and we'll be posting it on our website as well. You'll also have an opportunity to pose questions to our speakers, and we're going to ask that you use the Q&A box instead of the chat to direct your questions to the speakers. And you can find the Q&A box on the bottom of your Zoom screen. There's a little button there that has two bubbles, and it's labeled Q&A. And we'll be more likely to see your questions for the speakers if you use that. The chat we encourage you to use for comments and less specific questions. We do have a team member that's monitoring the chat, so you can use that to let us know if you're having any technical issues or you have any more like questions about how to interact. Yeah, again, we'll keep reminding you to put your questions in the Q&A box if you forget. So on that note, I want to give a quick shout out to our tech team working behind the scenes today. We have Usman and Ashani from the BC Health Coalition and AJ from the Council of Canadians, and they're helping us run things smoothly today. I think that's everything on the technical side. Let me introduce you to today's moderator, Penny. Penny McCourt has spent most of her career working with and on behalf of seniors in community and long-term care as a clinician. She's active in policy development, research, and advocacy, and she's the chair of Action for Reform of Residential Care BC, a citizens group working towards improving long-term care residents' quality of care and quality of life. So welcome, Penny. Thank you so much for joining us today and helping us moderate the conversation. And you're muted.
Thank you. It's my pleasure to be here. As you gather, seniors, I've been with seniors all my life until I turned into a senior myself, which is going to happen to a whole lot of us. This is a really important issue. These are the services that seniors today use, and seniors will be using tomorrow as well, like some of us. So I'm going to give us an overview of the agenda, which basically is that we have three excellent speakers from different perspectives, each of whom will speak for about 10 minutes. And followed by 15 minutes of discussion amongst them. During the presentations, people can put questions to the speakers in the question and answer box, as Audrey said, and we will be looking at those further towards the end. I think the 180 people, we should get some very good questions that, and I think a lot of the people, judging by the chat room visit I made, look as though they've got experience in this area. So that's great too. Okay, so I'm going to introduce each of the speakers, and not necessarily in the order in which they appear, but Sheila Pither is the president of the Council of Seniors Organizations of BC, which you might know better as Costco without the T. Sheila is going to talk from the perspective of seniors, access gaps, and in the continuum of care. Scott DeLong is the Vice President of Community Health of BC Government and Service Employees Union, and also works in the field of mental health and addictions in the community. He'll be talking from the perspective of workers. And finally, Anita Dixon, who's past president of the LPN Association, will be talking to us from the perspective of assisted living and issues that one sees there. So thank you very much, and let's begin. We're going to start off with Scott. So
good morning, everybody. My name is Scott DeLong, and I'm the Vice President of Community Health for the BCGEU. I'm coming from the traditional territories of the Songhees and Esquimalt First Nations in Victoria. COVID has absolutely exacerbated the gaps in care. And for my perspective, of the 16,000 members that are in the Community Health Bargaining Association of various unions, about half of them would be community health workers. Through this pandemic, we have had either a shortage of work for these workers as family members were canceling visits for community health workers, or we've had a shortage of workers. All this during the biggest transfer of private sector workers back into the public sector. It's something that I wholly endorsed, but the transition hasn't come without some hiccups. So the challenges facing the community health worker are really about recruitment and retention. In healthcare, we have different collective agreements. So for example, there's the nurses agreement, there's the facilities agreement, there's the community health agreement. And when you have a community health worker who has the same qualifications, the same education as a care aide, their working conditions are not similar. So in this healthcare industry, one portion of healthcare is cannibalizing other portions of healthcare. For example, community health workers tend to stick around for a short period of time and then grab a position in a facility, a brick and mortar facility, where they can have guaranteed hours. So under the current collective agreement and the current working agreement that community health workers have, they're not guaranteed a full day's pay. There's been occasions, and more often than not, due to one of the gaps in the delivery of care is the efficient scheduling. Workers have to be available to work available 9 hours a day to get paid for 8. So that means some point in the day, most of the workers are waiting in their car, waiting to do a visit, and they're not getting paid for this. The other big issue is the pay is not similar. A community health worker makes less than what a care aide in a facility under the facilities agreement. And because of COVID, when they've talked up all long-term care facilities to the same wage rate, community health workers don't get that rate. And it's something that we're fighting for and we aspire to. And because of that, because of these situations, community health workers get a little frustrated and tend to migrate over to long-term care rather than being in the community. Another challenge is, and I think is one of the biggest blights on the health authorities, and it's that community health workers don't get paid coffee breaks. Every other industry that I know of in healthcare, people get paid coffee breaks. A community health worker can work 8 straight hours without a break. They don't have a home office to go to. They have challenges using washroom facilities when they're out in the community. And they also face a challenge because of the volume of work to connect with an LPN or a nurse to get direction on how to provide care when something comes up. And so they will have their visits scheduled, and they're supposed to be scheduled 2 weeks in advance. This never happens. It changes day by day, hour by hour. And if someone goes in to see an unfamiliar client and has a question, they have to reach in and they have to pick up the phone and call the office to speak to a nurse. This is not expedited in any way, and they could be on the phone 15, 20 minutes. Meanwhile, this puts them behind their schedule for their next visit. We also have challenges in gaps in care when we talk about cluster care. Cluster care is a term referring to a small geographical area where a community health worker will visit. The challenge is that they have assigned 15 minutes to visit a client. And this timer starts when they arrive. So if they ring the doorbell and the client doesn't answer the door, it takes a few minutes. The amount of care that's given to the client has to be reduced. And it's a real challenge. And I've known, I've witnessed healthcare workers deliver eight hours of straight care without a break, without using the washroom, and rushing from one client to another. So the funding model for community health is they need to fund the worker and not the client. So a client can be assigned 3 different tasks that the community health worker has to be done, and each task is allotted a certain amount of time. And really, they should be funding the worker from the start of the day to the finish of the day, and not to be rushed. And they need to allow more travel time, especially in the lower mainland, between clients. And anecdotal stories of care workers getting involved in accidents because they're rushing from one area of town to another area of town, and they have a 10-minute window to get there, and there's traffic, and they're rushing. So you add COVID onto this, and it's exploited the weaknesses and and in home support, and how robust we need to make home support. That I doubt if there's an ongoing therapeutic relationship between the community health worker and the client receiving services. And one of the other challenges where things are being treated differently, and community health workers are definitely treated differently, is in the because of the pandemic, we're all required to wear masks when we go out into an indoor setting, or if we're going into the hospital. But the health authorities haven't required clients to wear a mask. So it's up to the community health worker to deem whether this delivering service to an unmasked client is safe or not, which I know that the community health workers that I've spoken to, the thousands that I've spoken to, they're doing this work because they care. And they will put their needs ahead of the needs they'll put the client's needs ahead of their own. So quite often you're going to run into circumstances where people are delivering care in an unsafe situation. And it just so, in short, we need to, if we want to maintain and recruit and keep community health workers or care aides that work in the community, we need to level the playing field as far as working conditions and caring conditions. Quite often, community health workers are working in homes without the equipment that they get in long-term care facilities. And if you speak to a seasoned community health worker, they will always tell you about their shoulders, their back, their knees, that over years of doing the work and repetitiveness of the work and the lifting and the transferring that they've done, they have some sort of injury. So not only are we losing people to go work in a facility where they can get straight 8 hours and get a coffee break, and they don't have to worry about making up their hours or filling out paperwork for missed payday, missed hours on their paycheck. We're losing workers to long-term disability. And then you throw in COVID on top of that anxiety. The workforce is really stretched at the moment. And the government is going to have to come to the terms that if they want to keep community health workers working in the community and not to filter off into a facility or another type of work, they need to level the playing field. And I think there's an appetite there. We're a long way away from negotiating our next collective agreement. But that's a challenge when one sector of healthcare is pillaging another sector of healthcare to deal with their recruitment retention problems. And I think one of the things that we need to do is to expand the role of a community health worker in the sense what they're qualified to do. And I think we need to get back to the basics where a community health worker has the time, has the ability to have a meaningful conversation with the client that they're serving when they ask the question, how are you doing today? That they have the ability to listen to the response with attentiveness. Quite often, they can't. They are so pressed when they are working to deliver the service and move on to the next client. There needs to be a little more of a holistic approach when it comes to delivering home support services. And for some seniors, this is the only contact they're going to have for 2 or 3 days to get service. And how heartbreaking it is for the senior and the community health worker when there's a moment where someone just needs to chat, just needs to share a little bit. And the system is not set up to provide that kind of service, that attentive ear. And to ask questions, if there's a medication change I understand that we're doing the best that we can, but that doesn't mean that we can't improve on it. And I'm passionate about the fact that the community health workers who are predominantly English as a second language, predominantly women, give so much to the seniors and yet get treated a little bit different than other healthcare sectors. So, I'm really grateful for the transition from the private sector back into the public sector for community health workers. And I've seen improvements in the service of care. It's been more collaborative, a more team approach. And, the challenges that these community health workers face, they work in isolation. They work alone. They don't have a centralized work site. And I don't know how working out there during COVID, the fact that they're delivering the care right now, the great care that they're delivering right now with a smile on their face is just a credit to what great people these are. So that kind of sums up the gaps. Like it's down to recruitment, retention, and we need to level the playing field, or there's going to be challenges down the road. And my hats go off to all these dedicated workers who go above and beyond on a daily basis. Thank you.
Thank you, Scott. That was really interesting and really illuminated the role of the home support workers in the system and also the importance of continuum, thinking about the system as a continuum. So our next speaker is Anita. And Anita is at an early age, her dream was to be a nurse, though she wasn't able to pursue this passion until later in life. After a career in office administration, Anita left Ontario and returned to BC to embark on her dream, first as a residential care aide in long-term care. There she became interested in the increasing use of LPNs and decided to further her education at Vancouver Community College, where she was honored with the Best Bedside Nurse Award. In 2001, she began working in the emergency department as an orderly, where she was trained in urologist assist and orthopedic assist. As an LPN, she's worked in many other sectors of the nursing field, including urology, orthopedics, med-surg, cardiac step-down unit, palliative, and hospice care units. Most recently, she completed a certificate in gerontology through Canadian Nurses Association. Anita's always been a strong advocate for LPNs working to their full scope as part of a healthcare team. Her most recent advocacy was her involvement in the research and publication of the place of assisted living in BC seniors' care system. Her passion is to ensure seniors get the best care possible. Thank you, Anita. That sounds like a really broad work history in this field, and we look forward to hearing your talk.
Oh, thank you, Penny, so much. I am honored to be part of this panel, this amazing work that you're also leading to. I would like to first acknowledge where I'm located and on the unceded territory of the Syilx, Okanagan. I'm up in the interior health, and I'm very excited to be part of this today. So I just wanted to, as you've heard my bio, I just wanted to also state that I'm coming from the perspective of assisted living. I was a manager for 2 assisted livings, one that was within the health authority and one that was 100% privately owned. Next slide. I've just identified through these slides here that some of the top concerns, but they are not at all, the only ones. I was just trying to identify for this talk today, and I think Scott has already highlighted amazingly some of the key points that we have. I've divided it into the 2, and is my role as the manager for the assisted living, that the top ones for all of the amazing care aides or the healthcare assistants was a heavy workload with minimal resources, needing more education and training, and then also that the staffing models, especially in the more for-profit and was definitely low, and then the low wages. Next slide. Well, yeah. When I became a manager of the first one, I was introduced and became very aware of the terminology underneath the Community and Assisted Living Act, and then the Assisted Living regulations. Was the whole primary circular was around the choice of being able to live at risk. I tried to delve into what does living at risk mean, and as I was embarking on this incredible opportunity to be part of the seniors in this new living model, and I found it already very quickly frustrating. I think that the main key point is when I see living at risk and I would ask, what does that mean? It was so many different interpretations, and it depended on who you were underneath and what leadership. And when I was first hired into one of the assisted livings, this one woman came up to me and asked me as a nurse, could I take her temperature? Immediately, my reaction was absolutely, why not? She says, I feel I have a UTI. I have them frequently. I went to go look for a thermometer, and I was told that no way was I allowed to do that. I was forbidden to do that, and I was wondering why. And so this poor woman they said, well, it's because she's living in her own home. This is not for you to do. And I says, well, I'm not diagnosing, I'm not doing anything. And I actually was threatened with my job because if I was to pursue this. So that troubled me. So then I went on to pursue more. So I still delved into the living at risk, and I will unfold that. We can go to the next slide. So part of my journey is then I started to try to understand what was the act about. And this is where I see gaps. And this is why I wanted to come back, because through my standards of practice and education research is that we have to be evidence-based. So we're looking at what is our legislation, what's our regulation, and what do we hold as our guides through our provincial government. And when I saw some of the key components for people being allowed into assisted living, and part of my role as a manager was to be doing the interviews, being able to invite them in and see, is when we have, and I highlighted the first one, unable to make our decisions on their own that are necessary to make sure that they are safe. What I saw, especially more in the private sector, is that the focus was more on the business model to make sure that there was no empty spaces or vacancies in the facilities. So sometimes you would have family members who were on caregiver burnout needing a room. They want to get in. So some would not be allowed in other sectors, but in the private sector, they would be allowed. And so that there would be sometimes a little bit of more of relaxing of the guidelines. And we knew that this person would not be allowed into the facility if it was using this definition. But because they needed somewhere to go and the family was begging for them and willing to pay, they were brought in, but they were already living at risk because they were not able to demonstrate completely that they were able to be safe or maybe put themselves at harm. And one of the concerns, or what I saw, was that somebody who had some early signs of dementia. And so there was concerns of will they be able to leave if there was an emergency? And the answer was questionable. And so the person was even having a hard time finding their way down from the room to the dining room. But we allowed them in because they needed a space. And so the ethical dilemma was presented very much so. It's these people needed help. And I think the biggest gap that we're seeing is around the whole mental health issues and what do we do with these issues and what do we do with these patient population and what does living at risk mean? So part of the discussions is that how about if we have more of a relationship, and that's what came out of that paper that I was involved in, is that we need to be able to support these people aging in place. We need to be able to help them stay there if they want to live longer. So I will give you, I have a wonderful example on the next slide. So we'll go to the next slide. So we hear all the time and we're told, and through all of our healthcare training, through, being as a healthcare worker or as a mental health worker, we're all having the training. And as we escalate and come up through the hierarchy or through the different designations, it even gets emphasized more is patient-centered care or resident-centered care. What we find, though, is that we have people that want to stay there, that they want to be in these wonderful supportive housing versus going into what still is concerning was the long-term care. But they are now not wanting to be able to tell you that they're having some healthcare problems. So some of the issues that I saw is that as we're having the people come into the housing, is that they were already having some healthcare issues. And part of the regulation was saying is that they need to be able to direct their own care. But some of them are not able to do that, or they're starting to age quite quickly. And so then they go into concealing mode. They don't want to tell you that they're actually needing more help because they feel that if we find out, and I'm going to use the terminology that way, if we find out that they're actually needing more help than what we can provide, is that they will be having to do an exit plan. When I was a manager, that was one of the pieces of my orientation training, was saying that as soon as someone comes in, we need to already start we have to create a plan for them, but we also have to have an exit plan ready that if they need to leave, they're very aware of that. And that's sad, because they have friends, they start to become familiar with the staff. And so that was an issue. As legislation started to change, we had to, when it was first introduced in 2002, and then there was a change in 2016. In 2019, the legislation lifted that there was whatever prescribed services we needed to offer. What we didn't see was the planning of how was the staffing going to be able to provide all those services if they need it. And what does that mean is, what is the limit? So there is more work that needs to be done about what do we provide as far as assisted living services for these residents, and when does that mean that they can still stay there, or do we have to start moving? And some of these assisted living areas are not designed to have like lifts. A lot of people are now starting to find mobility of being able to get out of their beds or being able to get out of their chairs. Even walking downstairs, there's now increased amount of walkers and wheelchairs, and some of the residents are actually mad at each other because they're saying, I didn't move into assisted living to see all of these wheelchairs or see all these walkers. So there's actually sometimes some internal angst with each other, which I had to manage quite frequently for all of that. And then it was hard for the staff to be able to deal with this. So we'll go to the next slide. What I saw when I was in there was some seniors, in order to stay there, was struggling to afford to stay in their home, which is what they wanted to be. That's why they went there. They knew that they were promised that if you're here and if you need more assistance as you start to age in place, that's what our services are going to be. What I witnessed in so many of these two housings that I was in is that they were afraid to say something, afraid to say that they needed some more help. Sometimes the patients were not coming out of the room, that it was too far for them to walk and they didn't feel well, or they weren't hungry, or they were depressed about finances because they were recognizing that they needed more. what I saw was the care aides and the housekeeping who would regularly go into the rooms were advising me that these people were declining and needing more supports. My role was to connect with the resident and then also connect with their families. What I saw was many times they say, well, my mom can't afford any more services. I'll have to come and visit more frequently. So then the burden would be dispersed amongst the family members, and sometimes they couldn't show up, or if the weather was bad, or if they were visiting. So then we would be worried about them, knowing that these people needed the extra help. And so then what I saw was many times the housekeepers or the care aides going into the rooms and helping them, or sneaking in there on their breaks. And just like Scott identified, many times that I would see the staff wanting to or giving up their breaks because they love these people so much. Next slide. So what I found was staffing for assisted living, especially working more in the for-profit sector, is that unfortunately, and I say this in kindness, is that when we have services for healthcare systems, the driver should be keeping the client in the center, not having to satisfy the investors or the people, the stakeholders. What I saw was the most stressful shift, and I will emphasize what Scott has already said. The most stressful times for any healthcare provider, LPN, healthcare assistant, nurse, doctor, whomever, is that when they are rushed and they go into a room and they say, I can't stay here any longer because you have only 5 minutes here, and then you have to go to your next client, and this person is saying, could you please help me? And you have to leave that room because you're on a time spot. Those are stressful moments when you get home. And that's when you start to give too much of yourself. And so then that self-care gets put to the sidelines. And I cannot tell you how many times I've watched my care aides sweating and running and having to say, and that weighs on them. And then some have their own burnout. Can you go to the next slide? So as we've all acknowledged, this gaps or the COVID-19 has brought and emphasized, and this is, I try to hopefully look at some of the phoenixes that are coming out of these, interesting times that we're having to deal with, is that this report and all of these issues are now finally getting back to the top of where we need it to be, and hopefully it will stay there, is that we need to identify and look at that. I currently am working in the emergency department, and what I do see, and I have actually, spoken to several of the physicians, in that we're seeing an increase of actual seniors coming in with failure to thrive. It's not the best diagnosis, but you can see it because they're not having the acknowledgement, and it's weighing on all of us in the healthcare system to see that. Also, we're seeing an increased amount of falls because they're not moving around, because they're being told to stay in their room. That's decompensation in their actual function. Assisted living acts saying don't bring them back because we don't have the resources. A lot of it is the staffing shortages. And then seniors not being able to see their families. And I hear that as a nurse, as they're saying, you're the first person that I haven't seen my family since March. Next slide. And I just wanted to close on my experience through assisted living. And I want to honor Val. Val came to me. She's a hematologist. She came from Australia, came back to live the end of her life. She was diagnosed with ALS, and she was in her more progressed state. And I was troubled because as a, part of my screening is to live by the regulations. And the very first regulation says I cannot admit somebody or accept somebody in if that person does not require care or requires more than 3 or 4 services. She was very quickly going to need to have a mechanical lift. She very quickly was going to need to have tube feeding because of the progression. She knew that. And then she says, I will be here only if I have to be here for a few months. What ended up with Val, and I want to honor her, is what you see a picture of her with her sister and her dog, because that was her life, is that we did end up, I had to go above and beyond, and the staff was amazing that I was with. We all gave everything, and we made it happen for her, that she palliated in her place, is what was part of the intention of being able to palliate in her home. But we had to go against a lot of rules. So for Val, I wanted to thank all of you on her behalf. She was able to pass away in her home, in her bed with her sister. And I was very honored to be part of that process. And I just want to thank you for that.
Thank you, Anita. That was really interesting, and I think it gave us quite a good perspective on the challenges that seniors are experiencing as they try and navigate or even stay in one spot in the system, in the current continuum that we have and the way it's set up. Okay, our next speaker is Sheila Pither. Sheila Pither is the president of the Council of Senior Citizens Organizations of BC, which is COSCO. It's a nonpartisan coalition with more than 75 senior groups across the province. She fervently believes that if we work together, we can protect and improve the well-being of seniors. Over to you, Sheila.
Thank you. Thank you very much for asking me to be part of today's panel. I am the president of COSCO, and what we basically are and have been for 70 years is a group of people, but large groups, small groups. We have, as Anita just referred to, the about 70 groups of seniors, some in, for instance, the BC retired teachers, at 17,000 we represent. And totally province-wide, we have about 70,000 people that we're in our umbrella, we call it. People can also join as associates if they don't have a group that they belong to. So over the years, the responsibility of COSCO has been to go to governments and say, look, we want the seniors to be able to do such and so. And when the pandemic came about, it became very, very obvious that COSCO needed to be involved. So we thought about where will we get our information, and we began to read everything that came out from other groups. We also knew that we needed allies, and we went to our, I beg your pardon, we went to our link with the National Pensioners Federation, because we knew that we needed to have representation both federally and provincially. I should have mentioned that COSCO has no office or any staff. We're all volunteers. So we wondered, what shall we take on as our role here? We decided that we would look through the lens of quality of life in the facilities. We know that it was a horrifying experience when people were made aware of the conditions of some of the long-term care facilities. And so what we did was we wrote some standards of care that should be there, and we went to the provincial government and to the federal government, wrote to the Prime Minister and the Premier, and we said, these are standards that we believe need to be there for people who are in long-term care. And so we also asked that the government would share with the opposition, and the opposition would be supportive of the standards that need to be established. So then came the speech from the throne, and we were really, really excited, because part of that was that standards would be developed nationally for long-term care. Right now, there are 13 different acts from the provinces and territories, but there are no national standards. So we thought, well, that's a big step forward for us. I have some concern that long-term care, being a provincial area, it's not going to be really easy to have the national standards adopted. And it's not going to be easy, I think, to bring to the table provincial and territorial representatives. Anyway, that was in the throne speech, and we were glad to have it. Also, in the same speech, the commitment was made to having pharmacare universal. So that was another aspect of the work that we've been doing for a very, very long time. But there are barriers that face us as we try to go ahead. And one of them is a kind of don't rock the boat feeling, I think, from people who have their loved ones in long-term care. And there's a scarcity of beds that people can rely on having when it's needed. So I think that that's one of the barriers that we have, is knowing what is happening. And it isn't a really situation where we weren't warned. We were warned. Roy Romano's report, Patricia Baird's report, our present Isabel McKenzie, the seniors advocate, the ombudsperson, all were saying for years, things are not being the way they should in long-term care. And that was ignored. Now we came to this horrifying situation, and we realized that greed had really created a lot of the problems, because some of the facilities were owned and were bringing in really, really good dividends for the private ownership that they were enjoying. And so it's one of our goals to have long-term care, a public service, not in the hands of private. So we are working on that. We're working on having various standards in place, as I've explained. Another barrier for us is that we feel that the ageism is a factor as well in terms of what has happened. We've been told for years, instead of saying, isn't it wonderful that in British Columbia we have people who can get older, they don't die as young as they used to. And instead of celebrating that, we were told that there would be so many seniors that the health care system wouldn't be able to cope. And dire predictions were made about how many, what percentage of people would be around in 2020, probably 2020, and here we are. So now what? Well, we're going to continue to approach both federally and provincially. We're going to approach those governments and ask them to participate in the talks that are going to need to go ahead. Meanwhile, we want to have more access to what is happening in the homes that are there now, and is there increased supervision, because we do feel that there has not been proper supervision, and there has not been proper from the provincial government's inspection of the residences and the facilities. So it's a busy time, and it's a time when we really do feel that our work has to be on both the provincial and the federal level. We're going to do that. We're going to keep on doing that. And we hope that the outrage that people felt when they first learned of what was happening and not happening in homes, we hope that that outrage will make the governments understand that we cannot go back to the way things were when our little victim, our little pandemic cause comes along, because we cannot go back to what was. We have to go into the future with proper care for our elders. I'm one of them. I'm 88, and who knows what my future will hold. Thank you.
Thank you, Sheila. Thank you very much. I think that all the barriers you mentioned are so important, and the ageism one in particular is a very hard one to get past, and it's going to take a whole societal push. I just want to say, listening to you all, that the COVID, in my view, and is only exposed, and I think most of you would agree, exposed and illuminated the many systemic and structural issues in the way that seniors care has been provided, particularly for the last 20 years. And I think that, you know, COVID is going to go away. And if we do go back to exactly the way things were before, if we don't make any really substantive changes, it'll be a terrible thing. You know, just the pandemic is not going to address those very powerful issues around the workforce that you mentioned, and the impact on seniors, the access issues, the barriers that people experience. So I think, you know, one of the things that really struck me is, again, to take action, it has to be a lot of voices together. And hopefully after this seminar, people will be able to sign up for different things that are working towards the national standards, which I agree with, but also towards changing things in long-term care today. We believe at the Action for Residential Care Reform that a quality of care and quality of life demands that you have a quality workforce, which demands adequate training, and also an environment, a quality work environment for the workers. So you really have to address the whole thing at once, I think. So maybe this next 15 minutes is going to be the three speakers asking questions of each other or discussing some of the points the other have made. Does someone want to start that off?
Hi, it's Anita. I would love to ask Scott the question around recruitment and retention, because you started your points that was your main, and then you ended with that emphasis on recruitment and retention. I know that that's something that has been on the ministry's radar. I think there was a call out to really bring in, I think it was like 7,000 workers in that. So I'd love to hear, you know, for the recruitment piece, if you can break it down into those two, recruitment and then how to retain them, because I think that's another issue. Thanks.
So yeah, you're referring to the Health Career Access Program, and it is targeting people that have lost work due to hospitality industry or the training to become care aides. And we've sat at the table. We agree with it. The classrooms are starting to get developed, and people are getting trained. When it comes to recruitment and retention, some of the challenges that we're going to face is healthcare is a 24/7 industry, and we need to lower the expectation of people that they're going to be working Monday to Friday, 8 to 4. That as the community health expands, as less reliance on hospitals and trying to keep seniors in their home as long as they can, as long as it's safe. For us, it's about adjusting to that, but it's also, and you mentioned it when you were talking about it, the self-care, the thoughts that workers go home with, where they see an opportunity where they could make someone stay or spend an extra 30, 40 seconds just acknowledging the wisdom and the presence of the person they're giving care, and they don't have it. So I think changing the model from funding the worker instead of funding the client would be a great help, and to give perks to workers that work evenings, work weekends, work nights, where in all other industries, if someone's working evenings and nights or weekends, there's compensation for working during those peak hours away from your family. And also, I think there needs to be a career path that once you become a care aide, what if you want to explore other career paths in healthcare? What if you want to become an LPN? What if you want to become an X-ray tech? Like, to make it robust and have the ability for care workers to move up, down, across the whole continuum of care. I think, but the primary thing that I think needs to be dealt with to maintain the recruitment and retention would be to level the playing field, to maintain great staff. I think it was Judy Darcy that said you can't separate working conditions from caring conditions. So right now there's a lot of pressure on community health workers because of the lack of community health workers during peak periods to do their job. And that's, so there's so many challenges. And I have a question for you. So what can we do out in the community to ensure that clients receiving care get the attention they deserve? Right now, there's a struggle when you're working out in the field to communicate with the office, because believe it or not, there's a recruitment retention problem for LPNs and trying to get to speak to one. Like, how do we change the industry so that we're responding to the client's needs instead of what they're being billed for?
Oh, Scott, you gave me a really, that's a great question. Because the interesting thing is that I want to bring in the whole single site issue, because part of being a manager, and when I was hiring and doing some hiring to try to have my staff in the more for the private, just doing care for the residents that they're serving, I found that they were, especially the night staff. So you talked, and I love that you've brought in some really key points that I hope all the listeners are really, taking note, is those, after hours. There seems to be somehow this perception in the newer generation that, it's this 9 to 5, Monday to Friday group, and healthcare is 24/7. And that needs to be emphasized so much, because I hear so many people don't want to do nights and don't want to do at weekends or don't want to do this. And the night staff that I found, she was not only having to answer all the call bells, and she was all by herself. And I have to give her a huge shout out, because I just have this beautiful, is that she was also being told she has to wash all the napkins, fold over 300 napkins, and set the dining room table, and vacuum, and having to do all this. So when I first came, it was overwhelming. And so the actual retention, we were just very fortunate. We had a person that loved her job so much, but that's not needed. We shouldn't have to have that. So I think the ethical dilemma as we start to do the career laddering, going from, because I was a care aide, I worked, and I did the, career laddering to go up to licensed practical nurse. And then, I aspire to stay here to, be able to, work with this level. But what I see is for the licensed practical nurses is, number one, having some experience to be able to help. They get overwhelmed. And part of the report that I was reviewed at, a lot of the interviewees said that they didn't have barely any orientation. And what I do find for LPN specifically, it doesn't matter what area of practice I have been, employed in. It's basically you get put into that position and you are orientated, and then you're just lucky if you can get a good orientator. See, because it's almost a survival of the fittest in our field. So a lot of them leave because they get overwhelmed. They have this huge portfolio of workload, and they say, I can't meet my standards of practice. I'm going to lose my license. So I think that's part of your problem. And then they don't have the experience. Some of them take these jobs because they're desperate for jobs. I find that for LPNs, but they don't have the experience to be able to help guide, carries. So what they end up doing is that they just say, do whatever you have to do. I don't know if that's another piece, but those are some of the key points. So I think we need to come back to helping each other. I think that there needs to be a better program to be able to help LPNs when they do go into these roles, especially out in the community. I have to acknowledge that the LPN program does not have a big, robust community sector for home support. They have it in working in residential care, but they do not have a lot of practicum in home support. So I think that's another gap that needs to be filled to have more experience. I hope that answers your question, Scott.
Absolutely. Thank you so much.
Okay. Sheila, do you have any comments to make or any questions you'd like to ask the other speakers?
Oh, with regard to Scott's question and Anita's questioning of what's happening, I think it's very, very important that people in the field prepare briefs and take those briefs to the politicians. That's where the power is. And it's really, really important that the government acknowledges that there are gaps in the system. They are not acknowledging that, to the best of my knowledge, at the moment. It has to be brought forward to them repeatedly. And we have prepared a set of letters that we're going to send to the newly named ministers, the mental health, Adrian Dix, the health minister, and 3 or 4 other ministers. And we're going to say to them, look, this is what's needed, and we're going to keep bringing it to you until you get on the ball and do something. There is the possibility of them attempting to avoid that.
Mm-hmm. I think in my experience, it's very hard to get through the door, isn't it? And I think when I think about the Royal Society of Canada that wrote that great report on long-term care, and with a big focus on the workforce, they talked about the number of reports that have been created, and only the ones we know about that have been published, right? The number of reports is phenomenal. There's no question that we all know, anybody out there in the field knows the issues that we've been talking about today. And I believe politicians know those issues too, but what's lacking appears to be the political will and the pressure, somehow the joint pressure, that needs to come from diverse populations, diverse communities amongst us together. That's something that we're trying to do with around long-term care, but it needs to be for the whole continuum. It's not really a continuum. It's really just a series of silos with very poor transition points between them, and I think when you think about the workers actually too, they're going back and forth. That's quite permeable, it sounds to them, and may not be the best way for things to be either. Any other comments or discussion around some of the issues that have been raised?
Scott here. I just, if I had a family member that was in care, and I don't at the moment, I wouldn't want someone working 16 hours a day to providing care at the 15th and 14th hour of their day, and that's common practice in long-term care, in assisted living, which I have a lot of members working in, and in the community. And the real challenge is when they see something that's not right, something that is wrong, they have an option to try to really, and the option is to raise their voice and say something, and in some cases risk being singled out for not being a team player, or to do the best they can with what they have. And I think we've seen a number of years of people doing the best that they can with what they have, and just accept the fact that the system is somewhat broken. And I'm a big believer that funding community health home support early on will establish someone staying in their home longer. which would save the taxpayer money at the end because they're not transitioning in a rapid rate into an assisted living or a long-term care facility. But there's the federal government needs to come up with a plan for seniors care. It needs to be federally mandated and funded. And right now we're struggling with that. So, and with a minority government, it's difficult to get things done. But I think everyone has been, for the past decade, been aware of the fractures in the system. And you're quite right when you say that we tend to be our own little silos. And the reality of it is that the only time these silos cross is when workers go from one job to another. It's not like I've ever sat down and had a conversation with someone that works in long-term care to discuss what our mutual problems are. So, but I think with the repatriation of home support back into the public system, there is an appetite for the government right now to fix the problem. How quickly, I'm not sure. COVID has put a lot of things on pause, and it's unfortunate. And some of the problems are urgent and need to be dealt with right away. But with the second wave hitting us, people are occupied doing other things at the expense of seniors, and that's a challenge. And it's ironic, under the guise of trying to assist seniors, they are by dealing with COVID, they're actually ignoring some of the major problems that are in the system of care.
Mm-hmm.
Yeah, I have to add to Scott, because I have to acknowledge too, for even if we were to come at a provincial level, so federal, having to cross all the different provinces. But I think I would even emphasize what Sheila has said, is come to our local government. We just we have a government that's engaged. We have a pandemic, we have the ministry. And I think that the challenge is going back to what Scott was identifying. If you have some passionate people speak up, there is that worry, and I've experienced it. That's so is that worry that you're going to be singled out, or you're going to lose your job, or so that's a I think we need to change that culture. I think we need to change that philosophy. There is some people who say, we want to hear from you, but then if it gets uncomfortable, we don't want to hear from you because there might be some issues there. I do believe that policy needs to change. I've just noticed some of the comments from the attendees is that we have that wave of the pandemic. It has given us this open door that we were absolutely, from the front lines perspective, begging for years. I've been involved in this for over a decade. This is something that we've been, I've listened to so many presentations around the senior care. We need to be ready. We need to, for all of the aging. And people do want to stay in their homes. I talked to our geriatric nurse just before I did this presentation. I said, what's the biggest thing you want me to say? And she says, she says, even my mother, they want to stay and age in their homes and be able to have that support. So I would say we need to be really looking at how can we do that. Thank you.
I think the other thing about that, yes, people do want to age in their homes, but at the same time, part of that is, and it can be very lonely, you think about social isolation, but part of that is because long-term care is so scary, and certainly COVID has amplified the scariness of going into long-term care. Not only is it a place where you think, naturally this is where I'm going to die, but it's a place where all kinds of terrible things happen according to, what has been exposed during COVID. My aspiration is to make long-term care a place that people are happy to go to, like they are happy to go to assisted living, right? Like people can see the advantages there. One of the things I think needs to happen within long-term care is that we turn it upside down totally reform it, so that instead of, the whole system being organized around when I need to go to the bathroom, if they answer the bell, about getting me in and out of bed, having my dinner, that's the background of my life. And I actually have a life in there. No matter what level of cognitive impairment I have, there's something going on for me. There's something engaging me. I am being touched by somebody's relating to me. I have a life, not just kept alive. I think if we could change that, and this is a bit of a silo approach, isn't it? But right now we have the focus on long-term care. I think, we have to work on all sectors together in order to make this really a continuum, because right now it's not, and it is. I totally agree about the under-resourcing. I think the point that Scott made about the funding the worker, not the client, makes total sense. Total sense. If you actually wanted to make a real change in the system, that would be one great big one. And I think finally that, as I mentioned before, common voice, getting our voices together is so important. And though we are focused on long-term care, and everybody's welcome to support what we're doing, and Usman will send out a link for you at the end of this. But I think that there's other ways of doing it too. Part of it is media, engage in the media.
Yeah.
But that being said, I know that families have been trying very hard and have had a lot of media attention to be heard by the ministry about their concerns about family members in long-term care during their lockdown. So even that's not easy, but it's a start. So, perhaps a media thing. And this is kind of provocative, but I was thinking when we were talking that my mom is a nurse, and she was, years ago in Manitoba, they all went on strike. In 2 days, they had their wages doubled and their working conditions changed, right? After years and years of being treated much as home support workers and long-term care aides are, as women who care and do the work because they really like it. And in fact, anybody could do it because we're naturally that way, right? And that's how nurses were viewed way back when. And that's what made the difference for them and professionalized them really in a meaningful way. So any other comments or discussion? We're close to the end of our time, but we still have a good 10 minutes.
So I want to comment. We're considered deemed an essential service in the province. So if we took job action, and you got to admit, most of our workers are barely making what a living wage is.
Yeah.
So the appetite, I would love to. I think we're making progress, but I would love the ability to put down our tools. But it's easy to do in the trades. It's tougher to do in healthcare, where there's emotional attachment to people you're giving care for. But I just want to highlight one thing that that hasn't been discussed today is the impact of COVID and the mental health among the workers. And it is getting exacerbated, especially when they've been working short. And these are schedulers for the community health workers. They've been working short. They've been working long hours, and the impacts of COVID and on them. And it's tragic to see high functioning people working under pressure for the last 9 months to actually see their mental health deteriorate to such a state that they no longer can function in an office environment. So I just want to put out there that the community health workers are at risk delivering the service. There's the secondary risk of people that are cooped up in small offices, scheduling community health workers that are suffering the impacts, not of COVID, but the mental health impacts of COVID. And my heart and prayers go out to them. And I think that there needs to be some form of support that the government or anybody can offer to these people to help navigate this unprecedented times. And with that, I'll just say thank you.
Okay.
This is Audrey. I can jump in with some questions from our participants, if that's okay, Penny.
Great.
Great. So I'm going to start with a question, maybe encouraging us to broaden the discussion a bit from Bev. She's asking, do our panelists believe that a perspective based on the social determinants of health calls for a reimagination of the overall care team? And if so, what does the new team look like?
I'm going to try to take a stab at that one. That one is a really good question. So if we were to look at the social determinants and, having the care team be, so it's part of our training. So I find that it is definitely embedded in nursing. I think that's where the ethical dilemma comes out, is that we know that we're supposed to be meeting these determinants for our, people that we're serving. That's the foundational piece. And it's our guide. but I think the team, it goes down to trying to survival, for the day. So I'll, touch on what Penny said and what Scott said, and what my, my experience and what I was trying to do in my presentation is that when you get in, you're wanting to do all this wonderful work, but all of a sudden you're finding that there's just not enough people to be able to spend that time to do the social determinants, to have that socialization, or to be able to see, do you have the engagement, what are your finances like, what is, that would be a luxury. And we all sit there and going like, how does anybody have time to be able to talk to them and ask, do you have food at home, do you have some of the basic needs, and can I get you the resources, and can I help you? So I think that to meet that, and that, I'll put up the other ones, is from my perspective is, and I know everyone cringes on this, but you're just going to need to have more people to do that, because it's going to take that engagement of turning this tide around of, just, running from client to client, and especially in, residential care. I just flash back on myself of, it's just got to get everybody to the breakfast table and eat, and then you feel like you've done a good job, and that's not how it's supposed to be. So I think that we just need more, health human resources is where it's going to be, so we can do those determinants properly. Thank you.
Yeah, I agree with Anita. I mean, the challenge is the community health worker go in the home and they don't have the time to do a food security check, to check and see if there's food in the fridge, and I think we need to break down the barriers in the teams. This is not a jab at any particular profession, but in healthcare, sometimes things go downhill, and it seems to be the least educated has to do the most physical labor. And I'll give you an example. In the public health offices, where you see a nutritionist or uh, uh, audiometric technician or a public health nurse, all those high touch cleaning areas that need to be cleaned due to COVID, you're not seeing a CEO, you're not seeing a manager do that. You're seeing an admin staff that's already workload is through the roof do that extra cleaning. So I mean, we've really got to work collaboratively as a team. And then from my end, for community health workers, we got to know what our discipline is and stay within it. We can't exceed. And somehow we do, I think, working collaboratively as a team with the occupational therapist, with the LPN, with the nurse, with the nutritionist, the community health worker. They need to meet together on a semi-monthly basis and do a review of the client that's receiving care. What are their needs? What is happening with the medication change? What is their nutrition like? What is their mobility like? What new exercise can we introduce? It's collaborative, but as someone referred to earlier, we're all in our rigid silos and we don't talk to each other, and that's challenging. And the client needs to be involved. The client needs to be involved to dictate the care that they want, and quite often they're being told, this is the care that you're given. So, but I know there's a will and there's an obligation to do better than what we're doing, and I'm optimistic that change will come. But one thing I know in my experience, change in healthcare is so difficult. It is difficult on the people working in it and the people delivering it and the people receiving it, because anytime you make a slight change, even if it's positive, there's going to be some form of resistance, whether from the worker or from the client, and it's challenging. And I speak from when we moved from the workers from these affiliate for-profit agencies into the public system. That change was pretty monumental, and it was difficult, even though, in my opinion, it was a change for the better. Thanks.
I'm maybe connected to this question of social determinants of health, which good job for taking a stab at that, Anita and Scott. Thank you. There's two questions from Tara and Ushnish about culturally appropriate care. So is there more funding for seniors care centers with a cultural perspective? And should more funding be dedicated for Indigenous and immigrant-led organizations to provide culturally appropriate elder care?
I'm good. I absolutely agree. I mean, we've had so many different cultures, in the Lower Mainlands, but even, across our province. But I think that, I want to respect, for the current, that we had the report and we heard what was being said about the Indigenous. And I think that that should be our focus. I mean, we need to honor our commitment to them. I think we need to do more. It hurts me when I heard that report yesterday in regards to any discrimination or any disrespect to anybody, but especially for our forefathers from our country. So I do agree that there needs to be more and into the different sectors wherever the person is residing. So I absolutely agree. I think we have a lot of work to be done on that perspective. And I hope that is a focus our government takes quite seriously. I saw that. Thanks.
I'm personally, I know that a client can request someone speaking the language that they're speaking, but that's to the extent of cultural sensitive services that I'm aware of. Now, there could be, and I'm not familiar with it, but I know that that a client who speaks Punjabi can request and receive care from someone who speaks Punjabi. So, but that's all the information I have, and that shows a gap right there. And I along the lines of Anita, we need to do more.
So maybe in our last few minutes, I want to share some questions from participants about the role of families. So one question from Nancy: what would home support consist of? And will family caregivers receive compensation or support for that? Can you comment on the role of families in helping seniors age well with the care they need?
I know in home support, their clients can be family members of clients can be trained to assist in lifts and transfers with a community health worker. About compensation, I'm not opposed to it. I don't know if it happens now. I'm not opposed to it, but I don't know what the appetite is for that. I mean, it is fairly challenging right now, especially the sandwich generation, uh, to deal with having someone requiring care and children requiring care and working full time. So certainly I don't see any objections to it. Haven't really given it a lot of thought, and it's a great question because I know we have people assisting healthcare workers that are trained by the health authority that are family members. That's all I know. Thanks.
I think, because I just was reading an article the other day that about a facility in Abbotsford that was putting a call out due to staffing shortages, asking family members that would be willing to come and help them with housekeeping and dietary, and and they were too willing to pay them for this. And they were wanting to, then that the trade-off, they could be closer to their family members. I thought this was interesting because I was really, putting my business hat on and wondering what would be some of the needs that we would have to put around liability. So if we're, compensating, who's going to compensate? So to me, there's so many questions around this concept of, how would you compensate them, and how would you make that a fair, equitable, and what would be the rate? I mean, I even was starting to drill it down to what would we do? And do we cover them through WCB or, our workman's, I don't know. So I think that it is an interesting concept. I do know that there's a tax credit for caregivers. And I think that maybe that's something the government can look at more, is to be able to give families more, through some type of incentive that way. But I think it's something to explore, because there is families who are willing to stay home and take care, just like they're doing their children, take care of their, their loved ones on the other end of the spectrum. but it's financially not possible. So maybe I think it's a great thing, but there's a lot to explore around that.
I think it's really interesting in these times, though, when so many people are struggling to be allowed into facility, you know, as essential caregivers or as social visitors for people, you know, who've been isolated for a long time and not being allowed in, or very unevenly being allowed into different facilities, that somebody would consider asking families to come in and pay them. I mean, I have nothing against that per se, but my point is that it's, you know, if you pay them, they're okay to come in, but you're not allowed to come in otherwise in so many places.
I know, I was really actually quite surprised when I read that article and it was put out there. I'm going like, this is an interesting concept. And you're absolutely right. There were so many questions of now it's okay, and how are you going to compensate them? And, you know, then I'm also thinking from the union hat, you know, you're taking right now and then when things get better. So you're absolutely right, Penny. Good points.
Okay, one more question about the role of families from Joanna. So there's a bit of context. The BC Seniors Advocate released a recent report on family visits to long-term care during COVID. She recommended that the family voice, family councils in long-term care needs to be strengthened. They are the early warning system for unsafe care and need to have an association and a process to lobby governments for better care. Can you comment on the present role of family councils in long-term care?
I can take that one, actually. With a lot of facilities don't have family counselors. That's one of the big problems, right? And the family counselors generally by their very nature are transitory, because, you know, you're on the family council because you have somebody there, and then you don't have somebody there, and then you're off. And there's been a big issue around, people doing things like management trying to run the family councils, which means they don't really have a voice. So that's been a problem for quite a long time. I know that the Vancouver Island Association of Family Councils is behind a proposal to the ministry for a provincial organization that's being supported by the Seniors Advocate. The Action for Reform of Residential Care is supporting that, and also looking at whether or not there couldn't be coordinators, family council coordinator positions, to actually help get family councils established, maintained, and educated as advocates. And that's my darn doorbell.
It does happen. I'd like to add to it, you know, coming from an assisted living perspective, I know that part of the regulations is to have a family council for, you know, to engage with, you know, the families and engage with the residents and have a say in the matter. I think it was very successful. I did read the Senior Advocate's most recent report in regards to, you know, the whole COVID and the response and engaging with senior care. I think we need to, I see Penny running, we need to definitely make that a top priority. I think, you know, again, if we come back to our foundational of what, you know, providing care is, making the patient and families engaged, that will take that whole continuum of being at home, and then when they're no longer at home, they need more help, bringing in assisted living, but the family and the residents stay always in the center and keep moving along, even into what Penny's you know, dream, which I think would be all of our dream, is to have residential care be looking at as a positive piece of their journey, not as a negative. So I agree with family councils. I like her recommendation.
So we are just about out of time. We have a few minutes. I'm wondering if there's anyone who has any last words, and Sheila in particular. We've been chatting away, so I want to give you a chance to comment before we close here. And Sheila, you're on mute.
Sheila, you can find your mute button down in the lower left-hand part of your Zoom screen if you just mouse over it. And it looks like an old-timey microphone and says mute on it. But if you have a line through it, it means you're muted.
Well, and while you're doing that, Sheila, any last words from Anita, Scott, or Penny?
I just want to thank you for the opportunity to present today and to hear that the listeners could hear about the working conditions and the challenge, and that I just don't want it to be construed as a lack of caring. And it's an opportunistic approach to line our pockets with more money. And trust me, there's not a lot of money, but it is because we care. And we got into this industry not because we wanted to get rich. We got into this industry because we care. We care about our our friends, neighbors, our seniors, and this is about providing better services to the most vulnerable of our province. And so, thank you for inviting me.
Sheila, I see you figured it out.
Yes, I did. I have enjoyed being here. I was kind of nervous about it, but now I feel empowered actually, because I think that for me, I got several ideas about what we should do or could do. One is we should have a summit of the various groups, the doctors of BC, etc., and talk about how things should be and how we're going to make it happen. And many of the suggestions that you have made, Scott and Anita, we did incorporate into our standards that we sent away to the governments, both provincially and federally. My last thought is they can't fire Costco.
Well said.
So on that note, Sheila, I have to tell you that it's you and all of the other people who still advocate, and even at your beautiful age in your 80s, that carry on, that we will be there, because I'm going to be a senior and I'm getting up there too in my age, and so I'm giving it all as I can. So know that I honor you, and I just hope that if our recommendations are embedded in what you have submitted, that they listen. They need to listen to the wisdom of what we know. And I've just been so honored that I've been part of today. So thank you, everybody. I just hope everyone enjoyed it.
Well, thanks so much, Anita, Scott, and Sheila. And thank you so much, Penny, for being here and moderating the conversation and bringing your insights as well into the mix. So I want to thank everyone for joining us today. We are out of time. The recording will be emailed to you. We'll send you a link, and it'll also be up on our website within a week, as I said. Yeah, thanks again, everyone. We look forward to continuing working on seniors care and all the partnerships that are getting built all across the province and even the country. So with that, I'm going to wish everyone a good rest of your day. Thank you.